Posterior labral repair utilizing a two-portal technique and the lateral decubitus position. For this technique, the posterior portal should be more superior and lateral than a standard posterior viewing portal, near the posterolateral edge of the acromion. This facilitates a more perpendicular trajectory for its use as a working portal on the posterior glenoid. After these portals with their cannulas are established, the fluid flow tubing is moved to the posterior portal to establish a sheathless setup, and the camera is placed in the anterior portal. Viewed from the anterior portal, extensive posterior tearing is noted using the probe. An elevator in combination with arthroscopic shaver and burr is used to define the tear and begin preparing a bleeding bone surface for repair and subsequent healing. Starting inferiorly at the 6 o'clock position, the curved drill guide is placed, drilled, and a knotless 1.8 mm fiber-tack anchor is malleted into place, and traction is applied to ensure appropriate seating of the all-suture mechanism beneath the face of the glenoid. A 45-degree curved suture passer loaded with nitinol wire, introduced via the posterior working portal, passed from posterior to anterior and retrieved again through the same portal. The blue repair stitch is then passed using this nitinol wire and prepared for tightening. Ensuring no tangles have occurred in the cannula, the now passed blue repair stitch is loaded into the loop on the preloaded tiger link suture. Pulling the other end of this loop strand, the repair stitch is now brought through the knotless mechanism and tensioned appropriately. After tightening, the remaining limb is passed through the anterior cannula to prevent tangling or knot formation in the posterior cannula. This can also serve to retension sutures after additional anchors are placed, as well as to serve as a visual marker of the needed location of the next anchor. Note that one posterior working portal necessitates removal of the suture passer device completely before retrieving this nitinol wire. Having more wire in the joint at the time of retrieval may prevent undue tension as it is passed underneath the labral tissue and may facilitate ease of retrieval. It is critical that while tensioning the suture as it is brought into the joint, knots must be completely removed prior to its passage through the knotless mechanism. Any knot will prevent its tensioning and may need to be cut out completely. This can be accomplished utilizing a suture looper, suture grasper, etc. under direct visualization. It should also be noted that plication of the posterior capsule can be efficiently and easily viewed and accomplished utilizing the anterior portal as our viewing portal and the posterior portal as our working portal. Here we can see again the crucial step of making sure that there are no knots present within the construct as it is brought through the tensioning mechanism on the knotless suture design. During the course of the repair, it is important to reevaluate the completeness of the repair performed on the posterior glenoid labrum. In this case, we opted to put another anchor in this location as it was still felt to have some laxity. Once the repair has been performed, the camera is moved to the posterior portal and the sutures are cut via the anterior portal. This facilitates flush cutting of the sutures. An arthroscopic probe can be used to determine the final stability of the construct. In this case, we used 5 anchors in total to achieve a good repair.